Welcome to tonight's webinar, which is responding to the challenges of Sydney WorldPride 2023. So good evening and thank you for joining us. My name is Dr. Brendan Goodger. I'm the General Manager of Primary Care Improvement at Central and Eastern Sydney PHN. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal colleagues joining us tonight, and I also acknowledge too that this is the 15th anniversary of the apology to the stolen generation. What I would like to do now is to introduce Dr. Phillip Read. Dr. Read is the Director of Sexual Health and Bloodborne Viruses at South East Sydney Local Health District. And then after Dr. Read presents, then we'll have a bit of a panel that will have Dr. David Baker, who's a GP at East Sydney Doctors at Darlinghurst, Dr. Rachel Thomas, who's a staff specialist, sexual assault and sexual health at Royal Prince Alfred Hospital. So, Dr. Phillip Read, can I hand over to you?
You sure can, Brendan. Thank you very much. Thank you to everybody for joining in. Let me just attempt to share my screen. Great. So yes, thank you very much for inviting me to talk. It's always a great pleasure to talk to colleagues in primary care, and I'm joined by some good friends on the panel as well, which is fantastic. So yeah, so I'm a sexual health physician and I'm the Director of Sexual Health and Bloodborne Virus Services in Southeastern Sydney. And in the next 20 or 25 minutes, the idea is to give you some snapshots of some of the things that are happening around WorldPride, some concerns, some excitement, some fun things, some things to think about, so that you can go away from here feeling a little bit more armed about some of the presentations and issues that might happen in primary care during this really exciting festival. So first of all, just in case you're not aware, I thought I'd give a little background on what WorldPride is. So this is a global pride event. It's organised every 2 or 3 years. And it's been going for about 20 or so years. And it involves a whole host of events right throughout the range of cultural experiences. So there's dance, there's theatre, there's music, there's politics, there's book readings, all sorts of different things. And of course, there's a lot of dance parties as well. So there's about 200 official events for this WorldPride, and there's a multitude of other associated events that don't form part of the official programme. It starts with concerts at Domain in the CBD. There's a human rights conference at the International Convention Centre. There are marches across the bridge. There's the Mardi Gras parade down Oxford Street, taking you out to Moore Park. There are pride villages located on Oxford Street. There's an arts and cultural programme and even a sports programme. And it's really anticipated that maybe between 500,000 and 1 million people might engage with this event at some point during that 3-week period. So Pride is the 17th of February, so pretty soon, up until the 5th of March. But the activities around there extend either side as well. And of course, many people in New South Wales will be celebrating and enjoying WorldPride, but we are expecting large numbers of interstate and also international visitors to New South Wales. And of course, that's part of the focus of this, is thinking about some of the issues that might present. So here's a map of where activities are. This is taken from the really fantastic, and I have to say very colourful, Mardi Gras brochure that the WorldPride brochure that the organisers produce, just highlighting the range of things. Now, I'm from Southeastern Sydney. The majority of events are occurring in Southeastern Sydney, but it's not just there. You can see there are some events there in Carriage Works, which is in the Sydney LHD area, and in Victoria Park. And I understand there are also events in other parts of metropolitan Sydney as well. But overwhelmingly, the majority of the organised events are occurring within the inner city, as you can see in that gorgeous map. So what about sexual health and WorldPride then? So I think just before we jump into this, it's really important to recognise that WorldPride is not one big sex party with people catching STIs. This is a really important cultural event There's lots of serious stuff that goes along. There's lots of fun stuff that goes along. And our job isn't to put a downer on that about worrying about sexual health, but it is important that we ensure that all those people participating in this really important event can enjoy Pride safely and healthily and know how to access healthcare if required. And also part of our role is to talk to our GP primary care colleagues to make sure you know where to direct people should they present to your teams. Now, obviously, sexual health is just one aspect of the planning around this. There's been large interstate multidisciplinary meetings with ambulance services, emergency departments, the festival team, PHNs, LHDs, and of course the ACON, the Community Organisation for LGBTI Health. But the focus of this talk is going to be sexual health, HIV prevention, and some party-related drug issues, which are the key focus, at least from my public health perspective. One of the key things about World Pride is preparation, and there's a lot of preparation going into the venue management, and there's been a lot of preparation going into the healthcare planning. One thing that ACON have really tried to push, and this is a screenshot from one of their campaigns, is to get people who may be exposed to sexual or drug-related risks during World Pride to prepare in advance, to get that STI check before the partying season starts, to ensure that people are fully vaccinated for all the various infectious diseases, new infectious diseases and old infectious diseases, which we know are circulating in the community at this stage. And also to make sure that given the possible demand on services, that people who know that they're going to need PrEP for HIV prevention or antiretroviral therapy for treatment of their HIV, access care, get prescribed those medications in advance so they're not forming a queue during World Pride to try and get what they need. So there's a lot of preparatory work. So if you're seeing people in this situation now, even though World Pride starts next week, it's still not too late to start some of that process. I just want to remind people at this stage just that there are guidelines around recommendations for sexually transmissible infection. These are guidelines taken specifically for asymptomatic men who have sex with men. There are guidelines for other populations as well, but you can see the host of blood tests and bacterial STI PCR tests that are recommended on up to a 4 times a year cycle for people who may be at risk. So those are the tests which ought to be offered to somebody who presents. And before we launched again into the nitty-gritty of some of the particular infectious diseases, I wanted to show you a little bit about what some of our district planning has been around access to care for World Pride. So you may or may not know, but within South and Eastern Sydney, we have a number of public-facing, drop-in and appointment-based sexual health services. So we've got the Albion Centre, Kirkton Road and Sydney Sexual Health Centre in King's Cross, Surrey Hills and the CBD. Short Street Centre down in St George, Cogra, based out of St George Hospital. And we also partner with ACON to deliver peer-based HIV rapid testing services and STI testing services through locations on Oxford Street and Elizabeth Street in Surrey Hills. And so you can see there the range of services that will be available with expanded hours and slightly increased staffing through those services. And I wanted to highlight 2 particular things. Number 1 is that we've set up a specific prevention hub located on Crown Street at the corner of Crown and Albion. And this will be an appointment-based and also drop-in service for free provision of PrEP, HIV PEP, monkeypox vaccine, mpox vaccine, HIV testing, asymptomatic STI testing. There'll be condoms and injecting equipment available for free and free rapid COVID tests. And you can see on the right there, there's a flyer promoting that. And we're really keen on people who fulfill those criteria to access that service preferentially to free up the other clinical services to manage people who may turn up with symptomatic STIs such as gonorrhea or syphilis or in fact even monkeypox. Bookings are available through the sexual health info link, numbers in the center there. And that service can directly book people into any of our clinics without having to separately call the clinic. So it's a great one-stop shop portal for people who may need an appointment. And I also found out yesterday that, to add to that mix, St Vincent's Hospital are also developing a similar sounding hub based out of their Sacred Heart Hospital location near Green Park. So that'll be an extra dimension for people to access. So these are all free services. And obviously, we want to be able to allow them to be accessible for people who otherwise can't access mainstream services. So in the next 15 minutes, we're just going to talk about a few issues. First of all, drug-resistant gonorrhea. So what do you need to know about that? I'm sure you all know about gonorrhea and what gonorrhea can cause in terms of urethral discharge, rectal infection, and often asymptomatic throat infection. Well, what's really important that we need to know is that in New South Wales over the last year, we've had markedly increased rates of ceftriaxone decreased susceptibility strains. Now, these strains often respond to treatment, but they're at breaking point with that level of treatment, and they're locally transmitted in New South Wales. We've had 20 or so of these cases over the last little while, both in the gay male population, but also in heterosexual transmission. So we need to absolutely be on top of drug resistance. And also, concerningly, we've had a couple of cases of ceftriaxone resistant gonorrhea and azithromycin resistant gonorrhea. They were mostly imported, but obviously with the influx of international people into Sydney for WorldPride, there's a strong concern that imported highly drug resistant gonorrhea could enter the New South Wales population. So what does that mean we need to do? We need to always use the recommended regimes or regimens for gonorrhea. So in person who's not allergic, ceftriaxone and azithromycin with the increased azithromycin dose if you've got throat gonorrhea. We want to get cultures before treatment, so we're absolutely sure that the drug's going to work. We want test of cures in those people where possible, especially if there's reduced susceptibility or we give an unusual treatment for some reason. We want to identify early and escalate resistance that's noticed in your culture tests to the local public health unit, to the local sexual health team. And there are actually outbreak response teams which do meet through teleconference when one of these cases is identified. And one of the things that we've noticed is it's quite hard sometimes after the fact to get good contact details. So sometimes when you're the diagnosing clinician and you've made this diagnosis and tell them about the resistance, getting some details on contacts at that point, confirming phone numbers and so forth is really helpful. And of course, sexual health services and the sexual health info link can help with contact tracing. That's, I think, the main issue I'd like to highlight with gonorrhea: drug resistance, getting the right treatment into the right person and doing the right follow-up. The next infection I thought I should mention, or next syndrome I should mention, is lymphogranuloma venereum. Some of you may have heard of this. It's pretty rare in New South Wales. We get a couple of cases a quarter usually. And they're usually imported from where it is a little bit more common in Europe and North America. And this is a cause of significant proctitis, often bloody proctitis and diarrhea, and sometimes ulceration, either around the bottom or elsewhere on the genitals. It's caused, as you may know, by a subtype of normal chlamydia, but this type, L1 to 3, invades the tissue, causes this massive inflammation and quite symptomatic infection. And so, of course, again, because this is not an uncommon infection in some other settings, from countries we know are sending a lot of people to WorldPride in Sydney, we'd like people to be on top of gay men presenting with symptoms of proctitis and treat them as if they've got something like LGV until proven otherwise. So what are those treatment guidelines? Well, it's treating for gonorrhea with ceftriaxone and azithromycin, covering for chlamydia and LGV with doxycycline, and some guidelines recommend adding in an anti-herpes treatment, particularly if there's ulceration in the rectum or around the anus. If you request LGV testing, if the rectal chlamydia test is positive, the laboratory should reflexively test for LGV. The test's actually got quite a quick turnaround. If you're managing that person and their symptoms are improving and their chlamydia test is negative, they don't need the 3 weeks of doxycycline, but LGV requires 3 weeks of doxycycline dosed twice daily. So those people should be given that until you know it's not LGV or until you've confirmed it's not LGV. Again, contact tracing, super important here, and a test of cure if the person's still in the country. So again, contact details involving the Sexual Health Service, involving the Sexual Health Info Link, who can help you with contact tracing, is going to be really key. And of course, the infection du jour is monkeypox, or Mpox, we should be calling it now. So this infection, as you know, became common globally from a normally very, very isolated, sporadic number of cases. We got to a situation globally by about July where there were up to 1,000 cases being diagnosed daily around the world. The UK, France, North America were the most initially hit, and then Spain, Italy, and now moved into South America. In New South Wales, we've only really diagnosed between 55 and 60 cases. Almost all of those, again, were internationally imported. We've had a couple of cases of probable local transmission, but there hasn't been sustained local transmission to our knowledge. Now, interestingly, globally, we're only down to 30 or 40 cases a day. And as I said, a lot of those cases are now in South America, but nonetheless, many attendees attending this festival may not be vaccinated for Mpox, the vaccine being the Jynneos third generation smallpox vaccine, which is available free through various vaccine sites available through New South Wales website. And the hubs that I mentioned, both the Crown Street hub operated by South Eastern Sydney and the St Vincent's hub, will offer free monkeypox vaccine to overseas travellers who arrive unvaccinated. So when should you suspect it? Pustular ulcerated lesions, painful lesions in the genital or even non-genital areas. People may have a prodromal illness of fevers, sometimes a mild respiratory type infection, myalgia. It can cause a nasty proctitis. And people can take up to 21 days to show symptoms after exposure. Really important to know that post-exposure prophylaxis using the Jynneos vaccine for Mpox is effective if given within 4 days. And all of those clinics will provide post-exposure prophylaxis. And I'm sure David later will talk about how access to both monkeypox vaccine or Mpox vaccine and post-exposure prophylaxis is also available in some dedicated general practices in the inner city. So identification and control of this infection will be a high priority, so much so that we've done mock desktop exercises with the Ministry and the Public Health Unit, role-playing outbreaks at sex parties and all sorts of things to think about how we respond effectively. So what practice points might we have here? So you use standard viral swabs. You can swab the blister itself, the ulcer. You should use contact and droplet PPE to do the swabs because it is an infectious disease. You should inform the laboratory that you're doing the test so they can get the gear ready. Although the laboratory the laboratories can actually test up to about 80 cases a day, actually, and they're very underutilized, so don't be afraid to test. You need to inform the public health unit of a probable case and provide them with the details, potentially also of the preferred language of the case that you've tested, so they can call them, check on their isolation requirement, check on their ability to maintain safety, and also start that contact tracing process. Of course, we shouldn't forget other causes of fever and ulceration in this population. And the Westmead Infectious Diseases team are our go-to expert team for this particular infection. So serious cases of very bad proctitis or eye symptoms can be escalated through Westmead. And you can also call Sexual Health Services or SHIL, the Sexual Health Info Link, for additional advice. I'll flag that there are health pathways already available for Mpox, and that vaccination with the Jynneos vaccine is available for free to anybody in New South Wales. Eligibility criteria are being a gay or bisexual man, or having sex with a gay or bisexual man, or being a sex worker. So it's fairly broad. I'll touch in the last few minutes on a couple of other things, PEP and PreP during WorldPride. So anybody suitable for PreP should be offered this either daily or on demand during and in advance of WorldPride. And obviously, we do want to make sure that party goers are protected as best as we can and they can against acquisition of something like HIV, which are both impactful for them, but also a potential public health issue within New South Wales. What we know from New York's experience in 2019 is there was high demand for PEP and PreP, both at primary care and emergency departments in that context. And so we've set up these prevention hubs and sexual health services to try and manage this demand. We've accessed free PEP and PreP, so there'll be no charge for the consultation or the medication for either local or overseas people. And just to remind those of you that don't know, basically eligibility for PreP now or suitability is pretty broad. If you have condomless sex and you're a man who has sex with men, or you have sex with a man who has sex with men, then you're eligible for PreP. And we can also prescribe it to anyone that we as clinicians assess as being at risk. I'll move on to the next slide, actually. So also HIV medications, we've got to think about that. We know that many people living with HIV in Australia are on treatment. In fact, about 93, 94% of them. But that's not the case globally. And so there may be people coming from countries to Australia who aren't on HIV's treatment, despite knowing that they're living with HIV. That's something to bear in mind. We also want to make sure that people who arrive with HIV treatment or then lose it or run out can access HIV medication so their viral load remains undetectable and they can't onwardly transmit that infection during their partying. So super important that we maintain U equals U, which is undetectable equals untransmittable. Underlining the fact that people on effective treatment cannot pass HIV to somebody else, and therefore maintaining their access to that effective treatment, as well as other things like condoms and PrEP, are super important over the next month. So if somebody runs out, what can you do? Well, there are obviously countries that are eligible to receive reciprocal health care, and giving somebody HIV medication is a criteria. It is something that you can give under reciprocal healthcare arrangements in an emergency in the countries I've listed there. Obviously, people who are PBS eligible coming from other parts of Australia can see a sexual health service, or better still, a specialist S100 general practitioner, or any general practitioner that's capable of prescribing PrEP, of course. Yeah, they have to be an S100 prescriber for the HIV medicine, but any GP for PrEP. Some private insurance companies cover the cost of this. Private purchase for those with the financial capability is always an option. And if none of these above options are suitable, then services such as the Albion Centre, Sexual Health Services and St Vincent's may be able to find a couple of weeks of free medication for people in an emergency to manage their own health and also manage the public health risk. And finally, just to talk about drug and alcohol issues. So we know that there are lots of parties going on across the city. Many people will be partying without using drugs or alcohol, but many people do make that choice, and we want to make sure that's as safe for them as possible. We know that in the demographic of gay men at this age group partying, there is a relatively high risk of a relatively high proportion might use drugs compared to the average Australian population. And particular concerns are always around alcohol, stimulants, GHB, ketamine, MDMA or ecstasy, and the ongoing mental health issues associated with high dosing of those substances, prolonged dosing, and sometimes the subsequent crash and come down that people can experience. The most likely interface that these travellers having with the drug and alcohol system will be through acute presentations with intoxication or overdose to our emergency departments, and that's probably going to be managed by our toxicology teams or drug and alcohol teams. But non-acute queries from patients can be managed through ADIS, which is the Alcohol and Drug Information Service. And if you're presented with people with drug and alcohol issues that you're not sure how to manage, there's a 24/7 drug and alcohol specialist advice service on the number listed there to get through to a drug and alcohol physician who can provide advice. I'm very interested in safer injecting. And of course, needle and syringe programs and pharmacies can provide both clean and sterile needles, other types of injecting equipment, and take home naloxone for people who may be at risk of drug overdose. And our consumer organisations, ACON and NUA, have peer workers working in some of these festivals, roving around, trying to keep people safe, referring them into the Mardi Gras medical services, and then potentially onward transport to hospital should any of these issues occur. And finally, gender affirming care. There may be people, of course, that come from overseas who are taking gender affirming hormones in the form of usually estrogen or testosterone blockers. And of course, running out or stopping some of those treatments for many people can be physically and very mentally distressing. Expertise in this area isn't uniform, but there are some fantastic GPs, of course, that work in the trans and gender diverse space. And some sexual health clinics will be able to see people for emergency care around this, although are more likely to only provide a one-off script for this population. I draw your attention to TransHub, which is a community website that has lots of resources for people who are from the trans and gender diverse communities, which will direct them in the right place. I'll highlight the STI guidelines, which I'm sure you're all familiar with, available through that link there, which goes through STIs, syndromes, and particular populations. It's a really useful and practical read. And I'll finish off by talking about contact tracing. So if you have a case of monkeypox or LGV or drug-resistant gonorrhea, I'm pretty sure the sexual health and public health units will be all over you. But if you diagnose chlamydia or gonorrhea or probably a normal case of syphilis, it's going to be up to you to help initiate some of that contact tracing. So I just wanted to flag some of the online tools that are available for that. So there's SMS and email options. And if somebody's met through an app, through a profile, Sexual Health Info Link can even look for profile pictures on hookup apps to try and let people know that they've been exposed to a significant STI or HIV. So always bear that in mind. There's a portal there for uploading information and the team will call you back and clarify. And these are the details for Sexual Health Info Link. So I think I shall stop there and pass back to Brendan and invite any questions to both me and enjoy a good panel discussion.
Look, thanks, Phil. It was an absolutely fantastic presentation. And now I get the chance to ask a few questions. And I'll try not to be too brutal. Look, my first question is this, right? Really to you, Phil, but also to the panel if they want to jump in. Firstly, as you've said, WorldPride is a celebration. But for those attending, they might well come up and say, well, how do I party safely? Because I've got alcohol, they've got different kinds of drugs. Is there a way in which I can party hard, but party safely?
Well, yes, great question. And so obviously, you know, from an autonomy and a harm reduction perspective, I would respond making sure that the person was aware of the risks with any activity, but if they took an informed decision to go ahead and use party drugs, then it would be our responsibility to ensure that they did that in the safest manner possible. And so obviously, if you're thinking about something like MDMA, well, actually, there's some general principles. Some general principles are to let people know to use drugs with friends, to let people know what you're taking, to pace yourself, start with a small amount, as long as, particularly if you've not used that dealer before, to space out your dosing. So a concern drug at the moment might be something like GHB. People typically take GHB at 1 to 2 ml doses every couple of hours. We'd really recommend people take a small dose, see how they feel, make sure they leave at least an hour, ideally longer between second doses. Sometimes it comes in larger bottles. We recommend people sometimes dye that bottle so that they know the red stuff is the GHB and the clear stuff is their water. Avoid using it with other drugs because that can contribute to the overdose impact. There are also recommendations around MDMA, for example, around water consumption. So you need to take some water, maybe 250 mils an hour if you're just chilling out, and maybe 500 mils an hour if you're partying and dancing hard. But you don't want to take more than that because there are some issues with overhydration as well. You need to schedule yourself in some rest time. Make sure that you've eaten and you're hydrated before you start. Sometimes people recommend electrolyte drinks as well. And of course, if you're in the minority, but important minority of people who choose injecting as their way of administering their party drugs, then of course access to clean needles and syringes is vital. Letting people know what you're taking, and also if you have the opportunity, providing the person with take-home naloxone. That's obviously originally designed for reversing opioid overdose, but we've had some cases in New South Wales of cocaine supply and other non-opioid drug supply being contaminated with fentanyl and other drugs like nizatine, which is a strong opioid. And so we're actually providing naloxone to people who use non-opioid injected drugs as well, because we have seen some cross-contamination and some overdoses in that space. So that would be my main advice. There's also engaging with peer-based organizations. So newer at these festivals have a bunch of peer workers called rovers. They're easy to identify because they're in fluoro colors and they go around the venues. And newer has a group called Dancewise. They're also festival party experienced peers who are good first ports of call. So letting people know they can look for these people. It's non-judgmental. They're not going to be arrested by these peer workers. The ambulance crew isn't interested in arresting them either. The police might be, but they're not usually in the venue at that stage. They're usually patrolling the venue with sniffer dogs and things like that. So they would be my main pieces of advice. I don't know if anyone else on the panel has anything to add to that.
I was just going to turn to Dr. Thomas now and say, look, we know that people are going to be partying. They're going to be having sex. Dr. Thomas, how can people have sex safely, right? What would you suggest?
Yeah, so I mean, in New South Wales, we've got something called affirmative consent, which is basically came into effect last year, which is basically just checking in with the person that you're wanting to have, sexually engage with, making sure they're not too intoxicated, and making sure that you're getting visual, like kind of verbal cues, physical cues from that person that they are consenting. One of the things that we find with a lot of our presentations to sexual assault is that drugs and alcohol are often used, and the most common drug is actually alcohol that is involved in a sexual assault. So I think making sure that you are with people, if you're drinking, making sure that you are able to, it depends on who the person is. So if you're the one that's asking for consent, if that person cannot even have a conversation with you, then you shouldn't be having sex with them. So or if they're unconscious. So there's lots of ways to check in, but in New South Wales it's just keep checking in with each other. Are you sure you're okay with this? We're going to use a condom. Are we not going to use a condom? That's another issue as well. Some people can consent to some sexual activity and not others. They may consent to a particular sexual act, but not to another sexual act. So it's just being open and having that open dialogue with the person you're having sex with, and making sure that you're checking in is basically what I would advise.
Look, thanks for that, Dr. Thomas. Look, can I add my own top tip in this one, which is watch out for your mates. All right?
Yeah.
Is what I would add to this. Watch out for your mates. Keep an eye on your mates. Now, Dr. Baker, you're a GP's GP. You've been practicing in this area for a long time. Any other top tips you'd throw into that?
Well, I think it's been very well covered, and also there's a lot more support now for people, domestic violence, assault, than there was a few years ago, and I've certainly seen that with a number of my patients who've been assaulted or sexually or otherwise, that the police are far more sensitive than they were. And I think there's a lot more also great online 24-hour help services. So that give people a lot more advice, and also a lot of support to GPs who really sometimes aren't sure what to do. I refer people to the Camperdown service if they've experienced a sexual assault, and they've been very well treated there.
I've got a couple of questions for Dr. Thomas coming up very soon. But David, if I can just come back to you, if I may, which is, I'm sure a lot of GPs are pretty familiar with this, particularly in our region. But if there are GPs that you know, that someone, a patient presents, they're requesting PrEP, but they haven't prescribed it before. What should they do? I think Phil sort of covered it off, but can you give us some practical advice on that?
Well, Phil did a great job of covering that. There's some very good material. I do some work for ASHM, and they have some great online 1-2-page summaries of PrEP. And PrEP is now very available and really very cheap. And it's great that it's going to be provided for free through the hubs. I just did a quick check online, and PrEP through somewhere like Chemist Warehouse is only $50 for a packet. So these drugs now are very cheap. On the PBS, it's whether you've got a pension card or whatever, but these are very available treatments. And PrEP actually works for in most situations for post-exposure prophylaxis as well. And that's another area that's a little bit trickier. But again, there's some great guidelines from ASHM, and also sexual health clinics are very happy to give advice. But prescribing PrEP is actually very straightforward. You don't have to do much, basically do a sexual health screen. The only contraindication, really, the major one is severe renal impairment. Otherwise, almost everyone can use PrEP. And it may be, there's different ways, of course. Continuous PrEP has the most data, but intermittent PrEP or on-demand PrEP is also very well supported. But I think there's such good material online. You could, in fact, people who think they may be prescribing PrEP in the next, as homework, could just go to the ASHM website and read about PrEP.
So what we'll do is we'll post those links. We'll send it out to participants from the ASHM. I know the material that you're referring to, so we'll do that. Now look, Dr. Baker, someone rings up your practice, right? They don't have a Medicare card. They've got no health insurance, right? Would you see them? They're asking for some help. What would you do? They're phoning up the practice. You know, it might just be a Saturday afternoon. They're pretty desperate. What would you do? They've got no medical insurance, nothing, all right? But no Medicare either. What can we do?
So if we're referring particularly to WorldPride,
yes,
a number of practices, including our own, have got some support to provide care for people ringing up in that situation. So we've got extra appointment slots. And I think we'd have to consider each person on their merits in terms of, although I think most people coming to Australia will have some financial support wherefore to even be here. So in general, we would have a private fee for them. But if they had absolutely no funds, we'd have to think about that on the day.
Phil?
Yeah, I was just going to say that, you know, I guess it depends a little bit what it's for, because obviously, you know, we're, as the public system, really happy to support GPs around things that we can manage, recognizing that, you know, there are a lot of things that GPs might be presented with during WorldPride, and, you know, the focus today is around HIV medications or PrEP or something like that. But in fact, actually, more often than not, people are going to have lost their, you know, antihypertensives or their diabetes meds, or have just got themselves, you know, a chest infection, or, you know, damaged their finger partying or something like that. So it's, you know, we're happy to offload some of those things, but I was really excited to hear Brendan and David about that expanded GP work. I think it's going to be a really great contribution to managing it. And I know that St Vincent's Emergency Department have set up a kind of ED avoidance tent, I think. So you still have to go through the St Vincent's ED, but if you are of low acuity, they will divert you out of the ED into something else, which isn't exactly a GP service, but it's a low acuity emergency room.
I think, Phil, that you made a very good point. I think we can get quite worried about some more exotic conditions that you've described, but if we think about who we've seen recently who are travellers, and the last few I've seen have had very simple presentations like a sprained ankle or very sore throat, tonsillitis. So I think there will still be a lot of what we see, and everyone attending is very well equipped to deal with these conditions. And then there'll be some slightly more esoteric things, and then things we really haven't seen before, but they'll be very uncommon, I think. And I think you've covered those very well, Phil, with talking about monkeypox. One story I love is that the first case of monkeypox in Australia was identified by a GP. So it shows that incredible skill of GPs and really seeing a needle in a haystack. So congratulations to my GP colleagues for that.
Now, look, Phil's given an overview of the sort of things we hope no one gets, right? And it's a bit sort of scary out there. Like, we just want to avoid all that stuff, right, if we can. And that's a good thing from a public health perspective. We want to avoid all that stuff. But nonetheless, what are you as a GP truly expecting? Are you expecting all those sort of things that Phil's got us slightly nervous about? Understand justifiably. But what are you as a GP expecting to see? What are the common presentations that you'll expect to see from those attending the WorldPride Festival?
Well, I think it'll be some of the regular stuff and medication lost or baggage lost. We know that's going to happen. People are going to lose pills along the way and various things. I think there'll be a bit of that. Minor injuries, minor regular infections. And then where I work, there will be a lot of sexual health screening, I think. But that's really what we do. So it will be more of that and PEP and PreP. So it's great to hear. I'd just like to know, though, if perhaps Phil can help with that, about do we have any ability to access PreP or PEP via the hubs ourselves, or would we need to refer the patient along for that?
Well, that was going to be one of my questions, actually, because what I was going to ask the question to Phil was, so Phil, we've got all these GPs out there doing the right thing. What support can you give them? And it goes to David's question.
Yeah. Well, I can give them support around the area of expertise that I have. There's lots of things that GPs do that I definitely can't support them around. But there's obviously sexual health info link during operating hours, which is opening, I believe, 7 days a week during Pride. For those GPs doing expanded hours, particularly to accommodate WorldPride patients, I'm more than happy to utilize the existing health districts on-call staff specialists for particular advice if needed. So there's always somebody on call for Sydney Sexual Health, Coach and Road, etc., who will be able to provide out of hours advice, assuming you're not doing clinics at 2 in the morning. So yes, and in terms of fast tracking people, look, we don't share a medical record system, so we can't make it quite that easy. We haven't got a dispensing mechanism. It's from the clinic itself, so we're not doing it through a pharmacy. But if a GP assess somebody as eligible for PrEP and sends them to the hub as a walk-in with a short note saying, I've seen this person for PrEP, they'll be able to be fast-tracked through and won't have to be re-triaged, I think is I wish I could make it smoother, David.
Yeah, well, that's good to know. So I guess a lot of people will have insurance, and if we write a script and it's $50 for PrEP, it's not, it's sort of manageable, and they may prefer that. In fact, that may be why they've come to the GP, because they don't want to go to a public service, perhaps.
Yeah.
But if otherwise, we could write a note if they'd prefer to get a free script and send them down to one of the hubs.
We're more than happy to accommodate that for those people for whom we're not providing 3 months at a time. It's more for here's a month, and it's either a service at the moment through my team is nurse practitioner, and on some days a sexual health registrar, depending on which day they turn up. But somebody who's able to prescribe, but the free stuff just comes as a month at a time.
Now, Dr. Thomas, Dr. Baker has seen someone. Details are a bit sketchy, not entirely clear. No offense to you, David. But he rings you up, right? And he says, this might be a case of sexual assault, or there's something around that kind of behaviour that may have occurred. What can you do to assist David? And what services are you providing during WorldPride in terms of sexual assault?
Well, first and foremost, I'd be very happy that David phoned me for a start, which is great. So in SLHD, and also just to explain about across the Metro Sydney, we would take calls through business hours from any GP, and with a lot of the events happening in Eastern Sydney, a lot of our patients would actually come under RPA, but there is a service over at St George as well, just to be aware, but that's not 24/7. But sexual assault is actually provided serviced for 24/7, and it's usually patients do present, sometimes just self-present to ED, but if they present to the GP, that first and foremost, if it's business hours, give us a call. Even if it's not business hours, you can still speak to the counsellor who's contacted by page. I think the first bit of advice I would say is just come from a place of believing. Whatever somebody tells you, come from a real place of believing, because actually that makes a huge difference to how someone will engage with our service and services in the future. If they feel disbelieved, they won't continue with police or with us. And it's a voluntary service if they want to come to RPA for forensic. It's completely voluntary. I would explain that to the patient. They don't have to report to the police. We would encourage them to report to the police, but if they don't want to, that's absolutely fine. We will still provide a forensic service. I also think it's really important that they know it's free, and it doesn't matter their visa status, their Medicare status, they will not be charged, and they will go through the ED system. So I think giving expectations to the patient about, first and foremost, what they want to do. Do they want to come and have a forensic? A lot of people don't actually want a forensic. They just want to be medically checked out, checked for STIs, worried about HIV exposure, which ED and sexual assault can provide as well. Pregnancy risk is also a bit of a concern. So, you know, these are simple things that even before they even get to us can be addressed. What I would advise is that you explain to the patient that it will be a process where they have to go through the ED, but they will be seen fairly quickly. But it is a process that may take a couple of hours. So practical things to say to them is, if you don't, try not to shower or change the clothes that you're wearing if you're wearing them. If you can avoid eating and drinking until you see the doctor. And obviously it's very difficult to ask someone not to use the toilet, but if they could, you know, not use the toilet, that would help. And these are like really practical things that you can advise to the patient before they attend the service. What I would also say is one of the things that we do find sometimes is that GPs are really helpful and want to do things, but sometimes taking sexual health swabs isn't the best thing to do at that time from a sexual assault perspective. So if the patient definitely wants to come and have a forensic, as much as it would be fantastic to do a sexual health screen, please don't do any swabs at that stage, because it may remove some vital DNA that we want to see, to detect. So these are things that, real practical things. So come from a place of believing, explain what the services that basically in Metro Sydney, we have North Sydney, we have St George, we have RPA, which is the biggest service, and we also have Liverpool, and we also have Western Sydney, which is the FMU. And I think the types of people that we're going to see over Pride are probably going to be over the age of 14, but it is important to understand that some of these services don't see patients under the age of 14. So if they're underage, then you would need to know which services. So Liverpool, North Shore and FMU out in Western Sydney would all see under 14s, and the Children's Hospital. But RPA will see anybody that's 14 years and above.
Right, that's great information, Rachel, because the other thing I'm picking up from your message is that you're basically available there to consult with GPs should they need to dial a friend.
Absolutely, yeah. I mean, we are more than happy to give advice over the phone. In fact, it's really good if you can actually call us in advance, because sometimes as well, people don't realize that there is actually we've got a window period of time that we can take DNA. So we don't want people to have expectations that they'll have a forensic if it was 2 weeks. At 2 weeks, we're unlikely we wouldn't be doing a forensic. So getting that very specific detail from us, it's usually within 5 days that we will see patients up to a week. They can have just a counselling response, or they can have a joint response with the counsellor and the doctor. So there's lots of options, and talking it through before the patient comes in can be really helpful. So even if you could give the morning after pill prior to the person coming into clinic, or you could make sure that there's no physical things that need to be medically cleared. So unfortunately, we are seeing a lot of non-fatal strangulation, and that is something that we would want to assess and see in ED as well, and it'd be assessed by the ED specialist. So if you're able to give us that information prior to them coming in, fantastic. If not, and the patient just wants to self-refer, absolutely fine. Or if they want to come via the police, that's another option as well. So there are many options.
Look, that's great, because I think what we've all picked up now, if in doubt, call Dr. Thomas. Now, look,
24/7.
24/7, we've got your number, and we'll post that in the chat. Now, look, just joking. Now, look, the other thing too that, and this is an open question now for the panel, is that if you've got someone who comes from, well, someone who doesn't speak English particularly well, what provision is there for interpreters, right? And how do we do it? Phil, do you have any insights into that, perhaps? Any interpreting services?
Yeah, so I mean, first up, just broadly, there is on the Ending HIV website, some of the ACON websites, and also in our written and poster information, sexual health and HIV information in a variety of languages. I can't list them all for you, I'm afraid, but it would be half a dozen or so.
Yep.
Then yes, so if somebody's identified as needing support around language, then there's the Health Information Interpreter Service, and there's a local number, and there's also something called TIS National, which we use. Now, it's pretty good for Mandarin, Cantonese, Japanese, Spanish, Portuguese, French. It's not so great for regional languages spoken in countries where there's less likelihood of an interpreter from that country being in Australia. So you can sometimes have a small wait, that's for sure. Sometimes helpful to pre-plan. So if you know that somebody is going to require an interpreter and it's not an emergency, you can book the interpreter in advance to know that the person's going to be there. But the nature of many of our sexual health services, and I'm sure some of Rachel's services, is that often it's not necessarily a hugely planned event turning up to the sexual health clinic. But yes, so they're the sort of things. Usually it's pretty satisfactory. We try and avoid friends, and sometimes the needs must, but we try to generally avoid friends and family members, asking them around sexual health and private information, basically because you do need to be actually qualified to be an interpreter. It's not just knowing a few words of French from school. And secondly, there's obviously confidentiality and intimate question things that happen during many of these consultations, which might not be appropriate. And you also don't often know the dynamic between that relative or that friend and that person, really. So we try to avoid that where possible. Also try to avoid borderline bilingual staff. You can be certified as a healthcare worker as actually genuinely being bilingual, but we try to avoid smatterings of Spanish or French learned at school. But again, sometimes you just have to communicate at the time, and you do your best.
All right, so there are some local options available, and what we'll do is we'll send them out to those people attending tonight. Now, look, I've got a joint question now between Phil and David, and you guys can sort of argue the toss about which part, but I might start off, maybe we'll start off with you, David, all right? Which is, just imagine, and we're coming close to time here, but I think I can squeeze a couple more questions in. I can't let you guys get off the hook too early. Now, look, a patient presents at your practice. It's 5 o'clock, on a Saturday. You just happen to be open, thanks to the PHN funding. And they present with skin lesions, right, on their hands, right? So it's pretty suggestive. What steps would you take for presenting with skin lesions? What steps would you take from there, right? And then I'm going to turn through to Phil in a second to ask about something, right? David, over to you.
Yeah, thanks. It's a great question. And we've had 2 people present with monkeypox at the practice. But in both situations, we're quite lucky because they did ring up in advance. If someone just rolls up at the door with suspicious lesions, then that's slightly more difficult because we need to get our PPE on to get a swab. Fortunately, it's not as contagious as COVID, but we still have to be careful. So if possible, we try and isolate the patient in a side room away from the waiting room, and then as soon as possible, and then probably contact Westmead as well as our local courier to organise the rapid transport of a swab. And I've found Westmead have been extremely helpful. But sometimes the local pathology company messes it up in terms of transporting the swab in a timely fashion. So the logistics have to be worked out. And also, we have to think about alternative diagnoses that Phil has covered nicely earlier. So common ones would be, non-sexual. So my one and only monkeypox I saw, it was very florid and there was very little else, although it could have possibly been a very extensive staph infection. So you need to think about all those things, get the swabs. And of course, the logistics of that are slightly tricky. You have to have your swabs organised, put your PPE on, get into the room, take a bit of a history which is always harder to do in PPE, and then get the swabs off to the lab in a timely fashion, and then involve public health unit.
So that leads to my next point. Let's imagine all the swabs have come back, like you're pretty certain it's positive. The lab results come back, it's positive, right?
Yeah.
And then then you've got to take the next steps. So my question back to Phil now is, this person may need to go into isolation. What are the accommodation options?
Yes, so this actually has occurred relatively recently in our service. As David alluded to, mpox isn't perhaps quite as transmissible as something like COVID and so forth. So isolation doesn't quite mean exactly the same thing. You can sort of isolate in the same house if you can have separate areas of it. But what we experienced was, and typical for people who are traveling is we had somebody who was in a backpackers or a hostel type environment. And so anybody that person stayed in a room with would be counted as a household contact, which would be high risk, which means they themselves would need PEP, and then and they didn't have anywhere else they could go. We arranged through the public health unit some special health accommodation. So they were put up by the public health unit in one of the CBD hotels, with whom they have a pre-existing arrangement for, which obviously started during COVID, but was morphed into a monkeypox response. So there is the facility to do that. But if people have no respiratory symptoms, they can cover their lesions, they can stay away from other people, they're not cohabiting in a room or sharing towels or pets or bathrooms and things like that. It is possible to isolate in a different environment. But if you actually can't do that, then yes, there is accommodation available, and the public health units have the capacity to arrange that.
So look, that's great information. Now look, we've come to the end tonight. I think we could probably go for another half an hour, but we won't do that. We will draw things to a close tonight. Can I thank Phil for your excellent presentation? David, for your local wisdom as a GP, and also Rachel for your specialist advice in relation to sexual assault services that you're offering. Really grateful for you taking your time out tonight. Now, look, this webinar is, we're being recorded. We are live, but we're being recorded. And so this will go onto our website soon, onto a YouTube channel, and we'll be sharing that to all the other local GPs and other primary care professionals who couldn't make it tonight. I think there's been a wealth of really good information that's been provided, really, really practical. So can I thank the panelists for taking the time tonight? Can I also thank all the questions? And so we're going to leave tonight. There's going to be a survey that'll flash up on your screens. I encourage you all to complete the survey. And I wish everyone a very good night, and thanks for attending tonight. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Happy
night.
World Pride.